So we did learn about penile clamp last time. So I'm showing you two different types of the penile clamp.
Oh, nice. You have like the full thing. I only had part of it, but that looks like a Cunningham clamp.
Yeah, and this looks more plastic material because I have another one. I'll show you this in all planes so as to appreciate it better.
And for those who weren't here last time, I showed a case of a Cunningham clamp, and it's used for incontinence. And yeah, actually, in your case, you can nicely see the dilated urethra proximal to it.
Mm-hmm.
And so it's sort of an external soft kind of clamp device on the penile shaft that helps the patient from being incontinent.
And this sort of area is this area where we do not see any material is actually the sponge material, which is very low attenuation, as good as air. And that is a different version. And I'm showing you the same patient with the conventional version which you had. So kind of metallic at the periphery. The one that I showed previously was plastic at the periphery. So similar thing.
Nice.
And
You said it's the same patient or different patient?
Same patient,
Oh, okay.
different
So
times.
they have two different types of clamps. Got it.
And the reason I'm showing you this study is for a non-radiologic entity. The patient had bladder cancer and he got instilled with like the regular treatment, which is gemcitabine and intravesical BCG. And then they kept following the patient for a long time. And at one point in time, the patient had some thickening, residual thickening in the bladder, which we do not appreciate much on CT, like this thickening. And when they biopsied it, it turned out to be nephrogenic adenoma. Again, there is no radiologic correlate. We cannot tell it, is it thickening? Is it tumor? Is it nephrogenic adenoma? It's an interesting entity. It is believed to be caused by at least, like there are two hypotheses. One is the renal cells from the kidney, they get dislodged and they get embedded in bladder mucosa, and then they form nests of cells, which is nephrogenic adenoma. And the second theory is after installation of the intravesical chemotherapy, there can be metaplasia in bladder cells, and that can also give rise to nephrogenic adenoma. And
nice.
I also show a couple of varieties, various different varieties of clamps. So probably this is the one that we saw, and this was more metallic at the periphery, and the softer version, like the plastic version, this is, which was the first image I showed. So that is follow-up number one. I have second follow-up. So we did learn about short-gut syndrome last time, Dr. Tan's case. So this guy had short-gut because he's a 23-year-old guy, and there was necrotizing enterocolitis. So they took away a portion of bowel. So when a lot of portion of bowel is taken, so the patient will have malabsorption, and the patient will also be susceptible to developing steatorrhea, which is reflected very beautifully in fat fluid levels. I've never seen steatorrhea like this, like fat fluid levels all across. Also, this patient, despite being young, had appendiceal adenocarcinoma, for which he was given chemotherapy FOLFOX, and he was immunocompromised for that reason. And he developed parasitic infestation of cyclospora, which is in the duodenum and jejunum. We see thickening and hyperenhancement, but these parasites do not cause steatorrhea, they just cause watery diarrhea. So he has reason for both watery diarrhea as well as fatty diarrhea because of short-gut syndrome. So that's about it for the follow-up, and I can...
Wait, Yashant, can you tell us more? You said they are under chemotherapy, so they're immunocompromised, and then they develop cyclospora?
Okay, sorry. Let me rephrase it. So all of us, can get exposed to cyclospora and cryptosporidium, but because our immunity is strong, we will fight them off and we will either develop a very transient diarrhea or we will not develop any symptoms. But if somebody who is immunocompromised, these parasites, both cyclospora and cryptosporidium, they have a chance to cause diarrhea or even worse symptoms. Thank you for
And the
finding.
imaging findings you're showing here, like they went on EGD and they basically were able to culture this parasite from that area. Is that
Yes, from this area.
Okay, cool.
Again, radiology is non-specific. The reason I'm showing is because I have never seen the fat fluid level like this severe steatorrhea in any patient.
Yeah, but the duodenal, I mean, those small bowel findings are also kind of impressive. It looks kind of frondy and thickened.
Yeah.
Very cool.
Okay. So this is a 50-something-year-old patient here for follow-up of pancreatic cancer. They are on chemotherapy. And that's kind of their pancreatic mass with upstream dilation and atrophy and whatnot. So what would we say about the gallbladder though?
I'm concerned about cholecystitis.
Right.
I've seen this where like the cystic duct gets obstructed by the metallic stent. We call it like getting jailed off. And then you get a secondary cholecystitis.
Right. So I think this patient was very sick also and neutropenic and whatnot. So we also called this like acalculous coli. We did an ultrasound the same day. There were no stones. It was just a little bit of sludge, but significant gallbladder wall thickening, hyperemia in the background of a neutropenic patient. So, but patient was so sick that they could not get a coli tube drainage from IR. So this is what they did instead. And I'll show you the scout if you can pick it up on the scout.
Oh, cholecystoduodenostomy, the axios stent.
Right. So I had never seen this internalization of the gallbladder like this. So they've created a cholecystoduodenostomy using the axios stent. So we've seen axios stent used for so many other purposes. This was my first time seeing this because the walls of this are pliable and it adapts just like with pancreatitis. It's creating an internal drainage system in those sick patients. So these are endoscopically placed. So just a cool different use of axios. Yeah.
I think Nelly showed us a case maybe like this.
Okay.
Where no, I'm just having a memory of it now, but where they used an axios stent in a different kind of way to maybe even then do an ERCP.
Yes.
Yeah. What was
Okay.
it? Like they had a gastric bypass and then they axiosed into, I don't remember exactly.
Yeah, that's right. It was, yep. So it was like a bypass altered anatomy, and then they went ahead and like somehow it was a few years ago when I was at Loma Linda, so it was like 5 years ago. But then they did like a GJ or something like that, and then somehow like got access to the biliary tree.
Yes.
Yeah, advanced endoscopy is so cool. They do so many things differently.
It's so cool. Oh,
It
I
is.
remember now. They did an axial stent between the excluded stomach and the pouch.
Yes. And so
It was
then
so cool.
yeah.
It was like 4 or 5 years ago that I shared that case. They
Yeah.
can do so much now. Like we had another case where they needed to do a jejunostomy tube. And so then they basically did like a GJ, but using an axial stent for decompression as a palliative measure in a patient with metastatic disease.
Can I share? I mean, I have two cases of different similar uses of axios.
Yeah, sure. Sorry.
So if there is a pancreatic pseudocyst which is abutting the duodenum, so they can drain the pseudocyst also with that. If it is near stomach, we can drain it from the stomach. If it is near duodenum, we can drain it via duodenum. And similar to Dr. Ram's case, So this guy had cholecystitis, there was stone, and then there was some inflammatory changes in the liver. He was sick, cholecystectomy could not be done, so then a drainage was done this way.
I'm amazed at how quickly you were able to find that. It looks just like Rupa's case.
Yeah.
Cool.
What do you see? Spleen.
That zebra artifact in the spleen.
Yeah, I've never seen this cool one, right?
Is this an artifact though, or is it like the
I mean,
red?
it's the red and white pulp, and then eventually in the later phases, it just homogenizes. We just see arcs and ring pattern all the time, but this is my
Yeah.
first one and only one where I've seen like a typical proper zebra.
It's
Very
a very organized spleen.
Sorry, I'll let Dr. Ram.
Okay, bit of a challenging case because of the arthroplasty, but the request or the reason for exam on this case was rule out vesicovaginal or colovaginal fistula. Patient had had some previous pelvic surgeries before. And the reason I'm showing you the delayed imaging first is we used this to first exclude a vesicovaginal because we did see good contrast opacification in the bladder and around the urethra, but nothing going into the vagina. So that was step one, was we kind of ruled out vesicovaginal. But then we saw some other stuff in the vagina, if anybody wants to talk about that.
definitely like fluid and then debris, held air.
Right. So fluid distension, this big lobulated pocket of air. And then kept following.
It
this
seems like
other,
it's going beyond the expected.
right.
Yeah.
So, and then we followed the colon separately. So colon looked like it was completely out of this field of view. This is the only area where we can tell if there was a tract where was it being obscured because of this artifact. But for the most part, we also felt like this was not probably colovesical. So bunch of small bowel loops that came very close to this area. So within limitations of artifact, we kind of said, we think this is a enterovaginal fistula, and kept looking at this structure here. And I thought that's the incriminating small bowel loop that comes to the vaginal apex. And
Is that Mickels? Sorry.
Is it what?
Mickels?
Meckles is a good thought. We kind of spoke about, is it like an inflamed Meckles that fistulized to the top of the vagina? That was one thought. But I'll show you the MR. And at this point, I called the urologist, the colorectal surgeon. Nobody knew any more surgical history than vague history that she had had some kind of pelvic surgery. And there were really
Yeah, is there
clear...
like some kind of hyperdense thing connecting to this?
Right. So this is the only thing that was unaccounted for, and we spoke about, are these some migrated clips or some
Or like a
retained...
colpopexy to the sacrum?
Okay, good, Aarti. I should have had you read this case. I'll show you the MR. And the difference is so obvious on MR because the artifact is so much lesser. So like Aarti said, on sagittal, the minute you see one image, it's a no-brainer. It's a big infected sacrocolpopexy mesh. And what we kept seeing as a fluid-filled loop of bowel on the CT was actually this loop full of fecal material. And just so much like the multiplanar capability of MR was so helpful. So this was actually an infected mesh, which had then subsequently fistulized through the vaginal apex. And then when we called the surgeons, everything else made sense because this was the surgery nobody had knew she had had, which with one sagittal imaging sequence, we were able to solve. So
and the bowel was not fistulized with the mesh too.
no,
Just
that was just the infected pexy, which amidst those loops look like small bowel on CT, but much easy to characterize on MR.
Very nice. I was,
Yeah.
when you were talking about testing for like the fistula with the bladder, you had the whole excretory phase. I've had a couple of cases where we're trying to prove a fistula between the vagina and the rectum. And we would do like a gastrograph and enema and not definitely see anything. And, but if you think about it, the enema is going up the path of least resistance, like up the entire colon, instead of out the tiny hole that's like connected to the vagina. So one time I actually did a vaginagram and injected, like put a Foley in the vagina, got like, inflated a balloon, injected that, and then was able to show the fistula. So sometimes you have to kind of like put the contrast in the smaller, more enclosed thing, if you can get a seal in the vagina, and that can prove it.
Correct. And somehow this often comes up on call too. They're trying to figure out which hole should the contrast go in. And I think thinking about it in terms of this, where gravity would take it in a supine patient would help.
Yes, gravity, that's another huge part. Like make sure
Yeah.
you, if like put the patient on the side that you think the fistula is going out. So
Correct.
if need be, they have to go on their stomach if you think there's like an anterior duodenal perf or whatever it is. So
Yeah.
cool. Okay.
This is a patient who, can you, sorry, stop and
Okay.
patient with history of renal transplant for renal failure from glomerulonephritis, and then also has a history of CLL, came in with abdominal pain. So the patient had like all of these like new like lesions in the abdominal wall, abdomen and pelvis, in the abdominal cavity. You can see right there along the right chest wall, left, there's like little implant, there's something there. And this is all new. And there's like subcutaneous nodules, and then also like paraspinous psoas findings here. All new.
It looks liquidy, so like more infectious than like PTLD, but maybe some kind of like immunocompromised infection. Anything growing out of their blood, or can you aspirate one of these things?
Yeah, so, and then patient also had brain imaging, and we see similar findings in the brain, like these room-enhancing multifocal findings, and also in the chest.
Aspergillosis?
So this patient, it was infectious. They did a biopsy of the left groin mass, and this was all nocardia, disseminated nocardia. So nocardia is commonly like it's in the soil, but in immunocompromised patients, they can get this through like open wound or like they can inhale it. And so it usually presents as a lung infection, but it can be disseminated like this case, and it can affect the brain and spinal cord like this case. And if it does affect the neural system, then the risk of mortality is pretty high, up to 80%. So this is a kind of a multi-system finding of disseminated nocardia in an immunocompromised patient.
Wow. Is nocardia a bacteria or a fungus? Just, do you know?
I thought it was a bacteria. But
Yeah,
let me
I'm
double check.
looking it up. It's a gram-positive.
It's
Oh,
a
that's right.
bacteria.
Yes, it's a bacteria. Yeah. Gram-positive bacteria found in soil. Yeah, in water and plants.
Cool.
This is a patient who got a CT abdomen and pelvis pre-bone marrow transplant for leukemia. First imaging study, and there was all of this finding in the pancreas. What would you include in your differential?
IPMN.
Yeah.
I had two
Yeah.
that looked like this. One that actually eroded, fistulized into the duodenum, and so mucin was coming out of the duodenum.
Yeah, so that's excellent. So I gave a differential like MCN, IPMN. I said, cystic spends, oligocystic serous adenoma, and then recommended EUS. So the patient underwent an EUS, and this was cystic neuroendocrine tumor. So here's the Dotatate scan that was done after the EUS biopsy finding, showing that this was like pretty high uptake. So cystic neuroendocrine tumors, they are rare. They're like about 2% of pancreatic tumors. They make up about 10% of pancreatic neuroendocrine tumors. So they're not common, but they're generally indolent. Like they have, they're considered well differentiated. They have low Ki-67. And, the thought is that the cystic degeneration hypothesized to be maybe due to like ischemia or necrosis or intratumoral hemorrhage due to like like a blood vessel rupture or kind of deterioration. So in the past, what I've seen is typically for cystic neuroendocrine tumor, thick enhancing wall with central hypo enhancing region like this. This is classically what I think about when I think about cystic neuroendocrine tumor. So a multiloculated cystic neuroendocrine tumor is like in this case is not common, but should be considered in the differential consideration. This is a really great review paper about pancreatic cystic lesions, and it's something that you can include in patients who have macrocystic findings is cystic neuroendocrine tumor.
Nice. Can you go back to your original imaging? I just want to see it again. That Dotatate is beautiful, by the way. Nice. Okay, got it. So it like what seemed to be like branching stuff is more like that's the sort of cystic part, and then you've got that like thick rind with the thick septations. Yeah, nice.
Maybe what's interesting also, we say it's cystic/necrotic when we see something like this on CT, right? But yet on DOTAS, we have cellular and
Oh,
hot
yeah.
appears.
Yeah, even the
Yeah,
cystic part had
mismatch.
pretty
Yeah,
high, like intense uptake. Yeah.
Very
I've seen
nice.
that on MR too. It can look like really bright, like on the T2, it'll look completely like a cyst, but then on the post contrast, it actually has like smudgy internal enhancement. So
Hmm.
it's very fluidy, but it's actually like you're saying very cellular. Which IPMN wouldn't look like that. Usually when they have malignant degeneration, they have like a little papillary frond that's enhancing, not like diffusely enhancing, but looking T2 bright. Okay.
Patient with history of cirrhosis had screening MR, and so this is a arterial phase. So there's multiple lesions. Here's one example of that lesion here. And then on the 5-minute delayed phase, it looks like it's hypoenhancing relative to the background. There's no enhancement, but it looked like it was, hypo relative to background. So on the in and post phase, this is a lesion here, but then you see the signal, it's kind of like blooming a little bit on the in phase relative to the post phase. And then on T2, it has this dark signal. Any thought as to what this could be?
Calcification.
Yeah, some calcified.
Or like a siderotic nodule.
Yes. So it's not calcification. Here's a CT. It was ISO on CT, so there's no calcification. So this is a siderotic nodule. So I want to, it's a known pseudolesion, and you can see that with iron. Let me share the article from AGR. So just it's a known pitfall with imaging patients with iron here. So there's a really great section here. So on MR, it can look like it's an area of washout, like this case, but it's just due to higher iron deposition. And I think for like the fact that we kind of see that blooming in phase, and plus the T2 dark signal, this is all related to underlying iron in that siderotic nodule.
I have a question. So here it says it's a dysplastic nodule. Do you know like how dangerous these nodules are, or like I had the impression that they're not as dangerous. Like they don't actually have usually high grade dysplasia kind of thing.
I think these are benign. I thought cytologic nodules were benign, and I don't
Okay.
think dysplastic nodule, like you can have, you know, low
Low-grade,
like
yeah.
high grade dysplastic, and then of course, you know, there's if it's a, you know, they can transform into HEC for sure. But I think, or my understanding is that cytologic nodules are benign. And I thought also like if lesions contain iron, it was generally like, you know, it's a good sign imaging wise.
Yes.
Um,
Okay. That's what I was thinking. So just making sure.
I have a really crazy case.
Okay.
So I'm going to withhold the history other than this is a otherwise healthy man who presented with adrenal insufficiency. Not an eyesight test. We have these bilateral adrenal masses, right? Very odd looking, some T2 internal T2 hyperintensity without T1 hyperintensity. You can see there's diffusion restriction in periphery. There's some extension into adjacent spleen on the left. And then there's a lot of enhancement in the periphery. And then on CT, the CT is a few months after the MR. You can see there's not much change, and you know there may be a little calcification inside this, the left. Any thoughts?
Victoria, we've seen a
Histoplasma.
few fungal, and like blasto and histo of the adrenals.
TB, some kind of infection.
Infection. There's something in the spleen as well, right?
I can hear you. What?
There's something in the spleen as well, right? I see something restricting.
I think you
You're
said it
very
was like
muffled.
growing directly into the spleen.
Spleen.
Right. So it looks like whatever something is going from the left into the spleen. Patient had chest CT recently, completely normal.
Probably
Okay,
check
so the
the urine
history of
for
this
all those
patient that I
antigens for infection.
the history that I withheld was the patient lived in went to work in Ecuador in the microbiology lab for years. Came back recently, and he did handle TB. He had no other
Oh,
symptoms.
wow.
Presented with adrenal insufficiency. No TB anywhere else, and he really doesn't want to get a biopsy. So we can never be 100% certain, but I thought this is pretty convincing that I've never seen a TB in adrenals before, but it seems like the ones what I've searched kind of looks very similar to what we saw on CT. So we kind of said, ideally you want to get a biopsy, but there's really high chances this is adrenal TB. Like this one looks very similar to what we have, almost identical.
And their
Very
blood
cool.
tests, like, aren't there, could they test their blood? I mean, I guess the sputum, you're saying like there wasn't any lung stuff, so you can't test the sputum.
Right. There was nothing anywhere. He had no symptoms. He did have obvious exposure. His lungs are pristine. He has no lymphadenopathy elsewhere. He has no symptoms anywhere else. Chest, literally the only thing that he presented with symptoms of adrenal insufficiency.
Victoria, we've seen this in India a little bit, TB adrenalitis, but not in this, maybe a subacute form. The ones I have seen are all atrophied adrenals with just calcifications, almost like a chronic or burnt out stage. But in endemic countries, I suppose isolated adrenal infection and then hypoadrenalism can happen. I don't know, Yashant may have seen.
I have a similar case, unilateral. I mean, once you're done, I can show that case.
And apparently there is a blood test for TB. There's two. They're called interferon gamma release assays, or IGRAs. And there's two approved in the US, quantiferon TB Gold Plus and T-Spot TB. So I would, if this person does not want to get a biopsy, I would encourage them to go get their TB test so they don't keep exposing people.
Yeah, the
Right.
quantiferon or the interferon test is even better because even if the patient has had BCG vaccine, so that PPD will still come positive. But with quantiferon, it is actually testing the organism. So that's a real gold standard currently available.
Nice.
TMESC.
Yes.
So it was more unilateral because the left adrenal looks fine. So that's the adrenal, and then it's probably getting into the liver, heterogeneously enhancing, a lot of stranding around it. And there's one retroperitoneal node here, and this was TB. So at least like unilaterally similar to Dr. Cherniak's
Wow.
case.
And I like how this also like has the central necrosis, but maybe even peripheral calcs.
Yeah.
So like necrotic calcifications, those are some buzzwords for TB.
Mm-hmm.
Cool.
This was contributed to me by one of my prior fellows, and this is a really cool case, and I'll let you guys take this case. I'll just scroll through on the axial images. So what do you guys see? This is scan number 1.
I saw a big hiatal hernia and then a huge peripherally calcified splenic cyst, which I would think in this is in the spectrum of like a post-traumatic cyst. It doesn't really look like a echinococcus.
Yes, so this patient was symptomatic because of such a huge cyst. There was like dragging pain in the abdomen, and she went and got this thing drained from the IR. And immediately after that, let's see what happens. What happened? So now whatever the hiatal hernia was, that has massively distended with fluid, and let's see what is happening. I can show curve.
Whoa, it's like the splenic cyst has ruptured and there's bowel in it now, causing a bowel obstruction.
Yes.
Wow.
So I thank my fellow Telly, who is in Idaho right now. He sent me this cool case. So basically what had happened was this post-traumatic splenic pseudocyst, when they aspirated it, because it was hard at the periphery because of the calcific deposition. So aspiration created a vacuum, and then it just broke at one place, and then the bowel got sucked in. And I think 1 or 2 days later, the patient presented with symptoms of obstruction. And then
And also, there's perforation, right? Like there's free air in that cyst now?
Yes.
Yeah.
No, that free air is because of the procedure, because they drained it.
Got it, got it.
And then when they went inside, a very long segment of bowel was ischemic. They resected it, but the patient ultimately succumbed.
Wow. Yes, and that is a massive gastric outlet obstruction.
Again, I've never seen, I mean, I can't even imagine something like this. This is like really crazy. That's
Okay, so the question is about the aorta. And whether or not it's thrombosed. Show you the axial. So it looks fine here. And then suddenly it's dark.
so is it like slow? It's not thrombosed. Maybe it's like the cardiac function is very low, and that's why we have ECMO cannula.
Yep. So yes,
And
and
it is very smudgy, the top portion which you showed. So
okay, so is it just because the cardiac function is bad? Like basically that you're saying the contrast peters out?
yeah,
Any other reason?
Do we know how it was injected, Aarti?
It was injected through peripheral vein, like usual. The contrast, yep. And it went through the arm. You can see like a little bit in the arm there. It went through the arm, through the heart, down the aorta.
are you trying to show some hidden fistula somewhere?
No,
Yeah.
I'm trying to show a known ECMO artifact. So this patient has VA ECMO, venous arterial ECMO. So the venous part that is sucking out the deoxygenated blood from the atrium is in the IVC here. And then, so VV ECMO is used for patients that have pulmonary disease where their heart is still functioning normally and can still pump out the blood. So you can put it back in the venous system, it goes through the heart and goes out. VA ECMO is used for patients that have cardiac disease and their heart isn't working properly. And so this is the vein sucking out the deoxygenated blood, goes through a machine, it oxygenates it, and then they pump it back into the artery. And in this case, they're pumping it into the common iliac artery here. And then it actually pumps oxygenated blood in a retrograde fashion into the aorta and then mixes with deoxygenated blood. But it's enough to supply the body with enough oxygenated blood. So this is a known ECMO artifact where the contrast bolus is coming down and your oxygenated blood bolus is coming up, and they meet here and you get like a sort of like a stoppage of that contrast bolus. Does that make sense?
Yeah, very cool.
Yeah, very cool.
Yeah, so the first couple of times we saw it, we were like, what is this? What is this? But there's actually a beautiful radiographics article about ECMO artifacts. So you can see it with VA ECMO, especially in the aorta, and then you can also see it in the aortic arch in patients that have like their catheters in the neck veins. And it's just like some of the flow dynamics and the mixing and stuff. So
I guess it's important to look in the chart to see which type of ECMO. I just say ECMO
yeah,
and
but in this
move
case,
on
you
in
can
a row.
actually tell because you can see
Yeah,
that it's
yeah.
the artery. But I did not know this whole like VVVA ECMO
Exactly.
thing
Yeah.
until like COVID came and my friends in the ICU explained this all to me. Like before COVID, it was mostly patients that were waiting for heart transplants and they mostly did VA ECMO because the heart couldn't pump properly. And even this retrograde flow is enough to send the oxygenated blood through the body. Whereas during COVID, they did a lot more VV ECMO.
Cool.
Okay. Okay. So this patient, you can see they're a little bit larger patient. I'm not even including all of the field of view. Do you notice any findings? They just had a sleeve gastrectomy a couple of weeks prior.
Spleen looks big.
Spleen looks a little big and a little bit like weird.
Hypo,
Hypodense.
maybe wedgie, like around the periphery.
Okay.
And then with all that fluid, there's also like in the liver, there's a little bit of
There's a little bit of
heterogeneity.
what?
Can you go like the portal vein, like where'd it go?
Exactly. So we want to clear the portal vein on every patient, right? And I think this is an easy one to miss, or sometimes people miss it because they don't look, but the portal vein is not opacifying here. And actually, if you go down, you can see that the splenic, the SMV is also thrombosed and kind of expanded and fuzzy. And so this is a case of complete SMV and portal vein, like acute thrombus after sleeve gastrectomy. And I now have like 4 or 5 patients after either Roux-en-Y bypass or sleeve gastrectomy that have thrombosed off their portal vein. So I looked it up in the literature. I think I've even presented a couple of these cases here. It's not exactly known why. Some patients who are undergoing splenectomy tend to have a higher rate of getting a portal vein thrombus because you're manipulating or moving around the portal vessels. So that's one reason if you're getting a splenectomy, but that doesn't explain like the gastric bypass situation. The other thing is, just patients like they sort of become pro-thrombotic in their post-operative state. Another reason is laparoscopic surgery. The pneumoperitoneum can actually change portal venous blood flow and cause it to be sluggish. So that's like another theory of why these veins get thrombosed. But anyway, I can say just from my own practice, I've seen this now a number of times, just like twice in the past few months. What they did in this case, they did a pharmacologic and mechanical thrombectomy, and then they actually did a tip shunt because the liver was so clogged up, they needed to sort of alleviate the clogging, like get flow through the liver. Unfortunately, the portal vein never recanalized, but they do have their tip shunt here now. So tip shunts can be used in both cases of Budd-Chiari as well as acute portal vein thrombus if the liver is just very congested and you need to get the blood flow out. And now you can see those splenic infarcts better. The SMV did recanalize, but the portal vein kind of did not. We were not really able to see it afterwards. So.
I think there was no other phase of contrast on the previous study also, right?
There was not. Why?
So that's what makes it harder also.
Oh yeah, and also like this
Yeah.
patient is larger, so there's just a
Correct,
lot
right.
of, artifact and stuff. But if you look, you'll see it. But yeah,
Correct.
great
Nice.
job, guys. Okay, so this is just a really quick kind of interesting case. This was a patient a few months ago. You can see their liver looks pretty good, looks fine. And then 2 months later, their liver looked like this. So what possible diseases do you think? And nothing else in the abdomen.
Candida.
Infection.
Yeah.
Okay, good thought,
Immunosuppressed.
good thought. Candida, often the little microabscesses are often smaller, but great thought.
Sarcoid.
Yeah, that's a good one.
Okay.
Some kind
And
of
actually
granulomatous process.
there's splenic lesions as well. So
I've
sarcoid.
seen lymphoma, like lymphoma can look
Yeah.
like anything, and I put it in there.
But 2
Okay.
months is a short time.
Yes, but aggressive lymphoma could.
Yes,
do it,
and
but-
I have a companion case to share about like how even in acute interval you can have
Okay,
findings.
pull it up while I finish up.
Oh,
this.
okay. All right.
And so anyway, sarcoid's
TB.
great. And I want to say one thing about sarcoid, which is that I've been fooled a lot in that like sometimes there's no lesions, but like you might just only see hepatomegaly or splenomegaly. And then like on path, there's like diffuse sarcoid. So sarcoid can be really tricky. It doesn't always have to be focal lesions. Same thing with lymphoma. I will tell you, it's neither of those. The patient had a
TB?
history of a primary malignancy. So any bad primary malignancy can blow up like this, but this patient happened to have uveal melanoma. And I just wanted to sort of highlight that because there are different kinds of ocular melanomas. There's uveal, there's choroidal. They are all lumped under this term ocular melanoma. And these have a very high propensity for going to the liver. So over 50% of patients with these eye melanomas will get liver metastases. And 90% of them will on autopsy will have mets in their liver. And they can be extremely rapidly progressive and then just kind of like explode in your liver. One of the exams that our oncologists like to do is like an EOVIST MRI, because any new lesions that pop up, they know that this is the beginning of sort of like, a rapid spread of hepatic metastases. But anyway, yeah, so this was just melanoma, and melanoma loves to go to weird places like the spleen and the gallbladder. In this case, the gallbladder is okay, but the spleen also did have mets. So just a really rapid progression of ocular or uveal melanoma.
This patient, the patient had rapid weight loss. Had a prior like pulmonary nodule, so then they got a CT to assess that, as well as like figure out what's going on with the weight loss. So there's like apical findings in the lung, and then the CT test was done for that. And there's also these like paravertebral soft tissue findings. And incidentally, they had noted there was a right adrenal lesion here. So then they got an MRI to evaluate the right adrenal gland lesion. And here's the MRI. So there's multifocal findings on the MRI. There was pancreatic findings here. There's kind of like an abrupt pancreatic duct cutoff. There was the adrenal findings were indeterminate, and the pre-contrast CT on chest was also like Hounsfield unit was like 50. So if it's over 45 Hounsfield unit, it's like malignancy until proven otherwise, irrespective of washout findings. But anyways, on the MR, there's like abnormal findings. You can see like the pancreas, there's like restricted diffusion in the body and tail there, at that area where there was like a pancreatic duct cutoff. There's also that there's like the continuation of the prevertebral findings into the abdomen and pelvis right there. And and then there's all this adenopathy. So right there. So, and all of this was new, and it was pretty like within an interval of like 2-3 months, all of this developed, and patient got bone biopsy, and this was acute myeloid leukemia.
Wow. That pancreas, like the sausage tail, I would have thought also like it would have been a good look for IgG4, but with all
Yes.
those findings, lymphoma is definitely top.
Yeah. So that was what on the differential, IgG, also like maybe like a pancreatic lesion there, like that we just really couldn't see because they had an obstructive look with the pancreatic dill, and
But the tail was really enlarged, like sausagey. So like normally if you have an obstructive mass, you get duct dilation and usually atrophy, not necessarily expansion.
What about if it's like an acute obstruction?
If it's along with pancreatitis, yeah. But this one looked like, I don't know. Anyway,
yeah, it was a differential either way, right? Like, and because of the adenopathy, I said, IgG4 and then, EUS. If I mean, like we because the adenopathy is way more than what you want to see for IgG. And anyways, there's multiple like findings that really didn't tie in together. And this was all acute myeloid leukemia. Or presumed acute myeloid
and when it
leukemia
becomes
based
like this,
on
is it
bone
now called
biopsy.
lymphoma or?
I don't know when you call it lymphoma versus
Leukemic. Yeah,
we need a
leukemic should be in the blood, right? But now it's like getting into the organs or like, yeah.
Yeah, lymphoma is more like if you see the solid lesions either in the parenchymal tissues or in the lymph nodes. Leukemia, as Dr. Shekhar rightly said, is more blood.
Yeah, so this was not lymphoma. It was called acute like myeloid leukemia. Even though we see soft tissue manifestation.
Yeah, I think they do call like leukemic infiltrates and stuff.
Maybe that's
yeah. Okay, it's past 3, so we got to go.
okay. Bye.
Great session, guys. Bye.
Thank you,
guys.
everyone. Bye.